to the type 2 diabetes population amongst those who are labeled or categorized as high-risk cardiovascular disease, then they should be treated with either GLP-1 receptor agonists or SGLT2 inhibitors at the beginning, and some patients who may consider combination. And another R factor would actually be insulin. One of them, which is available in UMMC, will be Ryzodex. There'll be insulin degludec aspart. And I'll also talk about how are we going to strategize the diabetes management. When do we consider the oral GLP-1 receptor agonist? It will be Rybelsus or oral semaglutide. And there will be certain patient group that we may consider using insulin therapy. So first of all, if we were to talk about GLP-1 receptor agonists, then various types of GLP-1 are available at a global level as well as in Malaysia. So if last time what we had were actually the daily injection, we call it as a daily liraglutide, can be used up to 1.8 milligram daily. That would be for diabetes indication, but we also have the 3 milligram daily that would be for obesity indication. Then earlier days, we have weekly isoniazid, but later that's been phased out. We also have the once daily lexisoniazid can be used up to BD dosing when we use as a combination. We call this as Soliqua. And the main thing that we're using right now, it would be weekly dulaglutide or weekly semaglutide. If you just see this label, one of the things that we start to learn nowadays would actually the first and only oral formulation of GLP-1 receptor agonist is the oral semaglutide, or the brand name will actually be Rybelsus. So what GLP-1 receptor agonists do be very pertinent for master students, master in medical research or master in clinical medicine. Common things that will ask you, how do GLP-1 receptor agonists act? So when you have ingested food on the gut, the food will have activated the GLP-1 response. And supposedly, the DPP4 would actually break down the GLP-1. But when we actually try to simulate the GLP-1 receptor using the GLP-1 RA agonist, this will actually help to enhance the GLP-1 activity. And why the enhancement of GLP-1 activity is important? Because it will act on beta cell to trigger insulin secretion. It will also act on alpha cell where they suppress the glucagon level, and hence we actually have the ultimate metabolic benefit of improvement of glycemia. If you look at the pathophysiological effects of type 2 diabetes, last time we were talking about 8 mechanistic pathways, and then now we also have 11 mechanistic pathways, and mostly will be involving pancreas, glucagon because of alpha cells. You also have beta cell when there's a reduction of insulin secretion. You have high adiposity. There's an increase of the kidney glucose reabsorption, or even there's a problems with the hepatic gluconeogenesis, as well as the peripheral muscle uptake. All these would have contributed to either increased insulin resistance or reduction of the pancreatic insulin secretion. But if you look at GLP-1RA, it's not solely working on the pancreatic beta cell or suppression of the pancreatic alpha cells. They also work on other mechanistic pathways. For example, it will actually promote the glucose uptake on the muscle, will improve the insulin resistance. It can also suppress the hepatic glucose production, and incretin effects will actually be enhanced. This is particularly important among Asian with type 2 diabetes because we know that Asians, compared to our Western populations, we are actually at a higher risk of developing diabetes and diabetes-related complications. And two pathways that are mainly highlighted would be our incretin effects does not respond as good as the Western population. And the second pathway is actually because we have a higher visceral adiposity. In addition to that, GLP-1RAs could also act on the brain. Will work on the neurotransmitter dysfunction, will reduce the hunger pang and reduce energy intake. There's an appetite suppressing effect. So when we talk about oral semaglutide, this is the first and only oral GLP-1 receptor agonist. And UMMC, we have started using it for some time now. The usual thing, then we were to start patients on oral semaglutide, and what should we tell them? There's certain route of administration. It would be best taken during the first wake up of the time in fasting condition, and you can take the tablet. It's only one tablet a day with less than 120 ml water. The maximum is 120 ml of water because of this specific mechanism to enhance the absorptions of oral semaglutide. Preferably, how long should they wait until they take the first meal of the day? They should have waited at least 30 minutes before eating or drinking or taking any other oral medications. But the duration of fasting matters. Most of the time when I tell patients, in order for you to gain the greatest benefits with the use of oral semaglutide is the longer that you manage to keep yourself fasted. This actually enhance the absorption of oral semaglutide. So showing here, if you're able to fast 30 minutes, the area under the curve will actually have been increased compared to just a 15 minutes of fasting. But you were to fast close to 2 hours before you take the first meal of the day, then you're able to have the highest area under the curve, the highest absorption of the oral semaglutide. So we have 3 doses of oral semaglutide, 3, 7, and 14. And how do we decide from there? When it's the first initiation, is preferably to start patients with the 3 milligram daily for the first month. Then if you can tolerate the gastrointestinal side effects, usually it will be nausea and vomiting. Some patients may have constipation. Some patients may have mild diarrhea. If you're able to tolerate that, you could actually intensify the 7 milligram daily for at least a month, then can push it up to 40 milligram daily for additional glycemic and body weight control. Elderly patients, are you worried about sarcopenia? The weight loss associated with oral semaglutide is mainly the loss of visceral adiposity instead of muscle mass. So there will be less worry on sarcopenia. We do not need to adjust the dose for oral semaglutide, whether the patient has severe liver impairment or severe kidney impairment, and there's no dosing adjustment needed. But it's not it's contraindicated to be started among those with dialysis or with an eGFR of lower than 15 mL per minute because of limited evidence. So if you look at the ADA-EASD, what would be the rationale for use of GLP-1RA? First, we know that with 5 pillars of the diabetes management, the first pillar will be related to cardiorenal risk reduction, and hence among those high-risk population like multiple risk factors or those with target organ damage or even those who have suffered from stroke or ischemic heart disease or peripheral arterial disease. Again, we can actually start them on either GLP-1 RA or SGLT2. And nowadays, most of the patients will tend to combine both. If we were to look into the importance of attaining glycemic goals, the higher efficacy could be made with the use of GLP-1 RA and as well as insulin therapy. Then what about weight loss efficacy? Of course, highest remains to be with semaglutide. And tirzepatide is actually low incretins, so GLP-1 plus GIP, which currently still yet to be available in Malaysia. So if you look at, as a summary of the rationale for the use of semaglutide, number one, we know that with the use of this oral GLP-1 RA, we're able to help us to attain glycemic goals. How much reduction of the HbA1c are we expecting? On the higher A1C level patients, they will responded better, but we do expect about 1 to 2% of the A1C reduction. We also managed to help patients to at least have a weight management and how much based on the pool of patients that we have at UMMC, on average, they're able to lose 5 to 10% of body weight. Cardiorenal risk reduction, from the Pioneer 6 clinical trial, that will be the initial outcome trial for oral semaglutide, have shown that's actually cardiovascular safe. And in terms of the secondary endpoint, there have been reduction of the risk of all-cause mortality, and we are yet to have a longer duration of cardiovascular outcome trials associated with oral semaglutide. We call that a SOUL study, will most likely be released next year. But if we were to look into injectable semaglutide from the SUSTAIN 6 clinical trial, have shown positive benefits in the reduction of MACE outcome as well as death. Again, some patients may not be acceptable to injectable, and some patients, they will actually prefer treatment initiation and intensification with oral formulation, especially those with just recently diagnosed with diabetes or those with a short disease duration, and hence oral semaglutide will have a stand in the management of type 2 diabetes. Usually, when we were to start patients with oral semaglutide, we actually preempt them on the potential GI adverse events that they may experience, because that would justify why is there a need for you to increase the dose of the first month as 3 milligram daily, followed by 7 milligram, and then you can actually push it up to 14 milligram daily. And what would be the common reported adverse events? Generally, is nausea, vomiting. Some patients have a mild degree or even moderate intensity of diarrhea. Some of my patients are actually complain of constipation, but it's actually bearable. They do not need any of the laxative or rectal enema, but mainly is by drinking more water as well as having a higher fiber intake. This in general tend to be transient and tend to decrease with time, and that's the reason why that the product insert or even the usual treatment recommendation is to start with a low dose first for a patient to get used to the potential GI effects, then you can slowly start it up. Another important thing is you also need to tell them that they have a small and frequent meals and try to avoid fatty meals, because this will actually help to minimize the GI adverse events. So sharing one case, they were 58 years old. This is a lady, diabetes duration has been more than 10 years, but A1C, the glycemia is still suboptimal control, 7.5% of the A1C during the recent blood test. Fasting blood glucose on the corresponding fasting blood glucose was 7.3 millimole per liter, BMI at the overweight area more than 23 kilogram per meter square. Kidney function still normal, liver function, there's a mild transaminitis. And her current medications included a triple oral combination therapy. There's a metformin, DPP4 inhibitors, and SGLT2 inhibitors. All three have been in full dosing. There's also on a high intensity statin, 20 milligram daily, and as well as bisoprolol. So because of this mild transaminitis, we know that she has MUSCLE-D. There's a change of the terminology nowadays. Apologies for the typing error. She doesn't have any other macro or microvascular complications. When she came in, her fasting, the SMBG diary, there's a higher fasting, but this high fasting, we need to eliminate the potential of nocturnal hypoglycemia, but that isn't. Her post-midnight glucose level was actually okay, meaning diabetes is still not optimally controlled. Probing further into her diet history, this is actually important when managing patient type 2 diabetes and not expecting all doctors to actually take a full diet history, just like a dietitian. They will do calculation of calories, etc. But at least we need to know what time do they take the diet, and then what do they usually take. So for this patient, they're looking at that generally as 2 slices of white bread during breakfast, half portion of rice, but it's a good mix with the vegetables and protein, and she doesn't take a lot of the sugar sweetened beverages. I would say her diet pattern would be good, and we shouldn't blame her for not having a good dietary patterns contributing to this suboptimal controlled diabetes. So looking at that, the discussion with her, because the overweight, there's A1C is still high, there's a transaminitis with muscle, counsel her for conversion of DPP-4 inhibitors to the oral GLP-1 receptor agonist, but still keeping the metformin and SGLT2 inhibitors, or also for the cardiorenal risk reduction. And she actually lost about 7% of body weight, and her HbA1c actually improved from 7.5% to 7% just within a 3 months period, 2.5 months period. I'm just looking at that. Her liver function has also improved when there's by having better glucose control as well as better body weight control. When I should ask her whether she has developed any of the GI adverse event when we try to intensify all this therapy from 3, 7 to 14, she developed mild nausea and vomiting, but she doesn't need antiemetic and can actually maintain with 40 milligram daily by having small and frequent meals. So that would be the beginning of the diabetes management, but some patients still require insulin therapy. When we're looking at what would be the patient population that require insulin, it can be straight away treatment naive when they actually present to you with osmotic symptoms, when they present to you having a HbA1c of more than 10%, or even when they actually have a random blood glucose of more than 13 millimole per liter. There are also certain group of people that you see generally in outpatient clinic. They have been on maximally tolerated oral glucose-lowering agents, but still remain to be uncontrolled, or some of them being referred to UMMC or some of the tertiary center. They might have been treated with either basal or premix insulin, but still remain to be suboptimally treated. This would be a group of people we need to really sit down, either yourself or together with your diabetes educator, to look into the patient's profile and see whether there's a need for us to change the treatment regimen. In general, when we were to talk about insulin therapy or even treatment intensification, patients would tend to talk about their fear of hypoglycemia because they may not understand what is that, what are the symptoms, and they are not sure how to counteract. And this would create resistance to changes to of treatment regimen. And some patients, they also thought that for insulin therapy, it needs to be multiple daily injections, either 3 times, 4 times a day. And insulin is a bit complex. If they do not have sufficient health literacy level or health numeracy level, it will be difficult for them to juggle. And then hence, how are we going to help them? Because some patients, they really need insulin. If you don't start them on insulin, you will not be able to treat them to target, and you will not be able to prevent them from developing complications. Hence, we need to provide them with a simple dosing regimen because we want to promote adherence, and we do not want to make them to be more confused about the diabetes regimen. And we also need to provide them with insulin formulation with a lower risk of hypoglycemia, because this will mitigate their fear. And once they are being more confident with you, the trust will have been built and will be easier for you to further intensify. And again, showing you this figure from our local CBG of the type 2 diabetes, we're able to talk about another, the second R factor would be on the use of insulin co-formulation combination of degludec and aspart, called it as Ryzodec. So for insulin, we have seen from here, most of them in general, we may consider intensification with insulin therapy. Just seen one patient during the screening activity just now at Plaza UMMC, found one patient diagnosed to have diabetes in June this year with an A1C of 9.5%, treated with triple oral combination therapy. But just now, A1C remains to be 8.6%, just with a reduction of 1%, and then the random blood glucose was 16. So for this patient, we actually require initiation at least of the insulin therapy, at least a basal, and we may consider an insulin co-formulation at the highest meal, heaviest meal of the day in order to normalize the glucose level. Talking about insulin, some of you may have experienced before I don't mean that you're old enough to experience the use of recombinant human insulin, and later you have seen the advancement of insulin over the past 100 years from rapid-acting insulin analog. Then we also have the biphasic insulin analog. This would be a general Novomix, and we also have a better generation of basal insulin. Would be we have Detamir. We also have insulin degludec at the global level, but not available in Malaysia. And now we actually have the co-formulation. It will be degludec plus aspart. So how can degludec aspart simplify the process of insulinization? It's actually a combination of basal. Degludec is the long-acting basal, and aspart is actually the rapid-acting insulin analog. And here, you see from here, the blue color line will be basal component that will good 24 hours or more than that of coverage. And this will actually reduce the glycemic excursion, and the patient is there will be additional prandial component to cover for the postprandial hyperglycemia. And how is it delivered? It's delivered with a special insulin flex touch pen, and 70% of them will actually be basal insulin, and about 30% would be the proportion for rapid-acting insulin analog. This is important for pharmacists because it's fully soluble. That there's no need for us to try to roll the insulin, and there's no need for resuspension. So we have come up with a practical guide of the use of insulin degludec aspart, and therefore I will encourage all of you. This is a very handy guide. Hard copy is just this small size, pocket size, but you also consider having a PDF. You can just bring up, just stay this for a few seconds, where you scan the QR code so that you can keep that in your phone for rapid reference. Okay, then I shall move on. So what does the practical guide of IDAC aspart cover? They actually cover the entire patient journey, whether there's a need to initiate when patient hasn't been exposed to any targeted glucose-lowering agent, or those who have failed the oral glucose-lowering agents, or you're pretty tried to administer using basal, but there's a need for additional prandial coverage, or even those who have been on premixes of basal bolus, but because of various challenges, there's a need to increase, to change, to convert to IDAC aspart. There's also additional stuff to talk about, the need for glycemic management to prevent cardiorenal comorbidities. We'll also talk about how are we going to consider changing or changing the diabetes management during Ramadan with the use of IDAC aspart. So I'm just sharing one example of how you intensify the treatment regimen for poorly controlled patients who have been treated with oral glucose-lowering agent. This is a 66 years old madam, long disease duration, more than 20 years, and she has had microvascular complication involving retinopathy and neuropathy, but so far she has not developed any ischemic heart disease events or stroke. She also has multiple risk factors: hypertension, dyslipidemia, and there's some visceral adiposity with a waist circumference of more than 80 centimeter. And we checked her kidney function. We realized that using the CKD-EPI equation, her eGFR actually 23, this is actually G4, and her urine ACR, she is having macro albuminuria or severely increased albuminuria, more than is actually close to 450 milligram per millimole. These were the medications when she had that kidney function kidney function monitoring. She was on ARB, CCB, she was on high-intensity statin, she was on sulfonylurea full dose, as well as a DPP4 inhibitors. And she came to you with an eGFR 23, albuminuria, ACR more than 400 milligram per millimole, as well with an A1C of 9.3%. And sometimes she does SMBG, pre-breakfast, were actually well controlled, 4 to 6, without nocturnal hypoglycemia. You need to probe further about that, and this has been confirmed during the clinic visit. And realized that she needs postprandial coverage because the post-lunch can go up to 12, and the post-dinner glucose can go up to 13. talking about the need for dietary modification as well. We look at other risk factors, home BP monitoring up to 135 of 80 millimeter mercury, and the LDL triglyceride was like high, 2.7, mainly it's actually related to her postprandial hyperglycemia as well. Of course, she had not been exercising, reflected with a low HDL level. So how should we manage Madam FLC? Just to give a few seconds for you to think about it. She has more than 20 years of diabetes, retinopathy, moderate NPDR, CKD G4A3, and she also has peripheral neuropathy, having high postprandial glucose level at lunch and dinner. So when Prof further again reiterate the need for looking at that, because nowadays we need these dietary patterns to help us to plan their diabetes management. And from what I've seen here, there's not much that we can change in the diet, because apart from asking her not to have too much gravy, not to have too much of curry, because all this gravy, they were actually high sugar content. So after discussion, she added insulin co-formulation, IDAC aspart, 10 units PD because body weight is 60. We were to start with a 0.3 unit per kilogram per day. That would be 18. So about 10 units lunch and 10 units dinner. And asked her to titrate weekly in order to aim a post-meal glucose lower than 9 millimole per liter. But also added SGLT2 inhibitors, mainly for her renal risk reduction, and of the sulfonylurea and of the DPP4 inhibitors, which means she's just needing BD IDAC aspart with further intensification and titration together with SGLT2 inhibitors. So she has shown good progress when we actually change her diabetes management. The orange color line, actually BD HbA1c has dropped from 9.3% to about 6.9% within just about 1.5 years period. And in terms of kidney function, when we actually treat patients to target, looking at the albuminuria, there's a lot of the reduction of albuminuria from 440 down to less than 100 over this period when we treat patients' glycemia well. And then looking at the eGFR, stabilized 23, and even there's this slight improvement, but in general, is not reducing in trend. So, and hence I've shown to you saying that certain group of people will require insulin therapy because they need that to help them to target fasting plasma glucose and postprandial glucose, despite the maximum oral glucose lowering treatment. And the progressive decline of the beta cell function will also let us think whether is that a need for us to intervene with the addition of insulin therapy. And therefore, one of the things that we can actually help to address the patient-related challenges would be minimize the complexity of insulin regimen, minimize the risk of hypoglycemia, and you may consider the newer generation of IDAC aspart. So it can be used in combination with OGLD. I've shown to you for Madam FLC actually combined with SGLT2 inhibitors. There is no need for other dose adjustment of the glucose-lowering agent, but that you should consider whether there should be a down titration of the dose of sulfonylurea or discontinuation of sulfonylurea. You may consider that especially when you foresee that there's a need for higher dose of insulin therapy, or you foresee that this patient would be hypoglycemic prone. So like Madam FLC have actually discontinued sulfonylurea because she has CKD G4. There's a high risk of hypoglycemia. She has peripheral neuropathy, long disease duration more than 20 years. There could be a chance of having hypoglycemia unawareness, and also see there's a need for higher dosing of the IDAC aspart, and hence sulfonylurea has been discontinued for case study 2 with Madam FLC. So how do we initiate? If we were to start, you can actually start with the 10 units once a day, but that with the heaviest meal of the day, with the heaviest carbohydrate content. Or you can even consider starting at a 0.3 unit per kilogram per day, for Madam Evos, I started with the 0.3 because based on experience, she has been on sulfonylurea full dose together with the DPP4 inhibitors, but A1C is still more than 9%. There's a need for you to start at higher dose instead of starting at the 10 units. So with the 0.3, she weighs 60 kilograms. Actually split into 2 meals, lunch and dinner, 10 units. There's no hard and fast rule. How do you split? It doesn't mean that for 20 units for Madam FLC, you really need to split at 10 and 10, but this is a decision that I made during the clinic consult. Some of the patients you may want to split. Dinner could be having higher carbohydrate content, and hence you can actually use a higher Ryzodec dose during the dinner time, but with a lower dose during the lunch hour. And how do you titrate? Usually easier to remember, just remember as a 2-0-2. As long as you're able to keep the patient within the target range, there's no change. Just keep with the current dose that managed to achieve the normal the preferred glycemic threshold. But what if there's a hypoglycemia? Then just minimize, reduce the dose by 2 units. If it's failed to achieve the dose, just increase it by 2 units. Just remember 2-0-2. If we were to look into real-world study using IDAC-aspart, these are insulin-naive patients previously just on background oral glucosidase agents. When we actually intensify the use of IDAC-aspart, we'll be able to improve the A1C by about 2%, as well as you don't expect weight gain with use of insulin, but despite of that, you're actually experiencing about 1.5 kilograms of body weight loss. So in conclusion, what would the R factor in the type 2 diabetes management? I think the first R would be the use of oral Rybelsus, that with the brand name, but the molecule name is actually oral semaglutide. We should actually target early initiation in order to help to normalize glucose level. You can actually tackle both fasting and postprandial glucose, and also to help patients to lose weight can be up to 10%. The cardiorenal risk reduction mainly right now is based on Pioneer 6, and the non-inferiority secondary endpoints have been positive for all-cause death, obese, the full cardiovascular outcome trials called the SOUL trial. Hypothetically, if we were to refer to sustained 6 using injectable semaglutide, it has been positive for cardiorenal risk reduction. And some patients we consider, because oral formulation tend to have higher acceptance level among those who have been just recently diagnosed. Then what about insulin would be IDAC-aspart, or it would be the Ryzodec as available at UMMC. They have a flat profile because of the good more than 24-hour basal insulin coverage and with a rapid acting of insulin, and this will actually tackle the postprandial glucose in a better manner. They have low glycemic variability, and of course they actually make effective reduction of HbA1c close to 2%, as what was shown you in the ARISE study, and patients don't usually gain weight, and they're either weight neutral, and some of them may actually lose 1 to 2 kilograms of body weight. So with that, thank you for your attention, and over to the chair, Jin Wei.
Wow, thank you very much, Prof. Lim, for such a insightful as well as educational sharing on the R factor, seeing how oral semaglutide being one of the R, as well as insulin, degludec, and aspart as the other side of the R on how it actually tackles the whole patient journey when it comes to type 2 diabetes management. And also, definitely the case sharing is very insightful as well as educational, seeing that both the R's actually have very, very good outcome at the end of the day in terms of managing the patient in whole. So for the floor, be it physical or virtual attendees, if you have questions, you can always write in the Q&A chat box, or you can actually unmute yourself, and we are more than happy to address any burning question on both the R that Prof. Lim have actually shared just now. So anybody want to unmute and any burning question from the floor? I'm not too sure, Prof. Lim, you can see the Q&A chat box from your end. Because I can see. Yeah, so I can see from mine. So probably we can kickstart with this first question over here. Prof. Lim, in a busy clinic, how would you follow up the patient on semaglutide or other GLP-1? Obviously, he or she might be talking about injectable as well, for the side effects as well as up titration. Yeah.
Okay, so you do not need to follow up regularly, actually. So I only refer, if I were to start patient on injectable semaglutide, then refer them to diabetes care unit. Diabetes educator, we have educated them on the injection technique. And that will be just once and for all. And usually in the clinic, I will just talk to them saying that this is the dose titration and why are we doing at the low dose initiation. I will write a small memo saying that after this date, there will be 1 month. So you just step up to the second dose. So we don't bring them back to our busy clinic just to see how do they tolerate the GLP-1 receptor agonist.
All right. So since we are touching upon up titration of GLP-1, how about down titration? So I believe there would be a time of, I mean, certain patient might actually requires a down titration. Probably Prof. Lim can share what are the observation that you think the patient might requires a down titration from a higher dose, and how can a busy clinic like what the attendees have mentioned can assist on this matter?
Okay, so I would say there would be two potential possibilities. Number one possibility, it would be there's a need for you to down titrate oral semaglutide if patients has achieved a very good response, meaning improvement in glycemia and body weight until there's a chance of hypoglycemia. Meaning you have already removed the potential hypoglycemia risk due to other background therapy, then there's a need for you to down titrate oral semaglutide. This group of people usually we see will be those that we have initiated early with a short disease duration, and this patient most likely might have gone into diabetes remission. Then you may want to down titrate from 14, you're down to 7, or those on 7, down titrate to 3, and you monitor patients 1 or 2 months. This one will be earlier, and see how it's respond. Then we consider even down titrate or discontinue if diabetes remission has been achieved. Okay. The second scenario, it would be patient may not be able to tolerate the GI side effects when they're up titrated. So I have a few patients that actually stay on 7 mg daily. I'm happy with that. I'm sure tried to push it up to 14 mg daily for additional glycemia and body weight loss effect, but patient couldn't tolerate the GI effects despite having small and frequent meal. But both of us, I mean the doctor as well as the patients, are happy with the metabolic response that they have shown with 7 mg daily. Okay, for example, they have achieved weight loss 5 to 10%, and they've even has achieved the glycemic target. Then I'm okay to go slow, just push it down from 14 to 7 mg daily. Some patients, this also they couldn't tolerate 7, so actually down titrate to 3. Quite happy they already managed to having an A1C of 5+%. They have lost about 8% body weight, then which is okay to keep it as such.
Great, great. As we can see with the multiple different strengths of oral semaglutide, it does allow a lot of flexibility when it comes to up titration as well as down titration. So it's about suicide risk in people on semaglutide. So yeah, I believe this is
Yeah, there have been reports about that. This mainly from the post-marketing surveillance, but so far, US FDA has not officially labeled it to be as such. So it can be obesity related because it may not be directly the molecule effect, meaning it's not directly due to the semaglutide or GLP-1 effect. Okay, it can be related to obesity condition on its own because mental health disorder associated with this chronic obesity condition.
okay. Yep, that's very clear cut. Okay, let's move on to the subsequent question, which is on Ryzodex. So Prof, how do you titrate Ryzodex? Is it based on the fasting or the pre-meal reading?
Okay, so if we were to start patients on Ryzodex once a day, so get a diet pattern and decide which meal is the heaviest carbohydrate dense. I mean, the heaviest carbohydrate meal. So for example, if you are seeing a patient, the heaviest meal is actually dinner. So you're giving Ryzodex daily during the dinner time, And how you titrate, you check the post-dinner 2 hours. It can be 1 hour, 1 to 2 hours, because this is a rapid acting. And you can check the next day of the fasting glucose level for you to decide whether there's a need for intensification.
Okay, I see. Great. So hopefully that does addresses the concern raised by this attendee. So from the floor, any ongoing or burning question, you can always unmute yourself or tap in at the Q&A chat box. Okay, probably for myself is with there's a question probably for Rhizodec. I mean for insulin degludec as well as aspart. So for this insulin, this newer so-called newer generation insulins, Prof, from your experience, how do you see the hypoglycemic rate for this particular insulin? Does it really has that low rate of hypoglycemia, and probably any explanation on that?
Yeah, I mean, the newer generation of insulin, the rate of hypoglycemia is actually much less compared to human insulin, even compared to the older version of the analogs. Okay, so this is true whether looking at general diabetes population, type 1 diabetes, type 2 diabetes, elderly population, or even those with advanced CKD. So when we compare the risk of hypoglycemia using the newer generation of insulin, I mean IDEC aspart, mainly because of the basal insulin component, degludec, compared to human insulin for sure, even compared to other older versions of the basal insulin analog, the risk of all-day hypoglycemia, daytime or nocturnal hypoglycemia has been lower across these patient subgroups that I mentioned.
Okay, thank you very much for the kind explanation.